Welcome to my video. The topic of the video is Health Risk Models Evaluation in the Application of Medical Use. We will first illustrate some concepts with examples and then reproduce the data. Finally, I will talk about the new types of application of the model. Now, let's first talk about the main idea of risk model. A risk model is a statistical procedure for assigning to an individual a probability of developing a future adverse outcome in a given time period. The assignment is made by combining his or her values for a set of risk-determining covariates with incidence and mortality data and published estimates of the covariates' effects on the outcome. Such risk models are now very important in the practice of medicine. The utility of a risk model is determined by two components, accuracy and precision. Accuracy tells us how well the model predictions agree with outcome prevalences within subgroups of the population, and precision is the ability to discriminate those with different risks. In this video, we will emphasize on the measures of accuracy and precision and compare performance for different risk models. In medical field, the health risk model is widely used in three kinds of applications. The first application is to determine eligibility for a randomized clinical trial involving a treatment with serious side effects. For example, we should use the risk model to determine if it is necessary to use tamoxifen to prevent breast cancer, as it may cause other diseases. Usually, a woman whose BCRAT assigned risk is greater than 1.67% is high enough for using tamoxifen. In this case, a good model is one that yields low proportion of women whose assigned risk is greater than 1.67%, but actually risk is lower. So, for this kind of application, it requires a model with high positive predictive power. That is, do not treat one without illness as being ill. The second application is to improve the cost efficiency of preventive intervention. For example, choose between MRI and mammography for detecting breast cancers. MRI detects breast cancers earlier but costs more and produces more false positive scans compared to the other one. Therefore, we need to reduce costs by restricting MRI to women at high breast cancer risk. For this kind of application, a good model is one that has high sensitivity and specificity for high risk, and it requires both positive and negative predictive power. The third application is to facilitate personal health care decisions. For this kind of application, it requires a risk model to be accurate enough at individual level. Now, let's see some basic concepts for risk models. Consider a population of women at risk of developing breast cancer within a 10-year period. Then, for each individual, the probability of outcome is determined by some covariates by some relation. As covariates and risks are grouped into finitely many discrete categories, we present all risks as discrete. Then, the population risk distribution and covariates distribution have the relationship in current page, and we use Y to indicate whether a woman suffers breast cancer in 10 years or not. There is a property that, with the same expectation, the variance has the lower bound of 0 and upper bound as the variance of Bernoulli trial, which can be explained by the tower property at the bottom. The performance of a risk model is best evaluated by applying it to individuals independent of those used to develop the model. As we cannot assess accuracy at the individual level, we instead assess it at the group level by measuring agreement between a woman's assigned risk R and the outcome prevalence pi R to see the ability to sort the population into subgroups with different true risks. We also measure the precision of a risk model, and a perfect model P is developed for comparison. Now, let's see the statistical measures for accuracy and precision. Accuracy is also called calibration, and it can be measured by the calibration bias, the difference between assigned risk R and outcome prevalence pi R in the subgroup. Now, we use an example to illustrate. In the picture, there are two populations, A and B. The first row shows the distribution of true risk. The second row shows the distributions of outcome prevalences in subgroups determined by a risk model based on two covariates, which is Model 1, and the third row shows the outcome prevalences in subgroups obtained by expanding Model 1 with an additional covariate, which is Model 2. Calibration can also be displayed by attribute diagram, which is a diagram constructed by points of assigned risk and outcome prevalence. For a perfect model, these points lie on the 45-degree line. The picture shows the attribute diagram that assigns the risk calibrated in population A by Model 1 to population B. As A and B have different population distribution, the calibration bias is shown in the diagram. There are also some other measures for accuracy. A model's accuracy is often summarized by its overall calibration bias, which can be obtained by taking the expectation on the square of calibration bias. The value reflects the discrepancy between assigned risk and outcome prevalence in the entire population. Moreover, we can use the hypothesis test to test whether the model is well calibrated or not. However, a p-value for statistical significance is less informative than an attribute diagram. Now, let's turn to the precision part. Most precision measures are related to pi and the model variance. It can be verified the model variance is equivalent to the covariance between the outcome prevalences within assigned risk groups and the individual outcome indicators Y. The model's precision loss is the difference between the maximum risk variance and the model variance. The larger the model variance, the smaller the precision loss. Another measure is called prevalence outcome correlation coefficient law. It measures the extent of correlation between individual outcomes and the outcome prevalence within risk groups, and the square is called Yates slope, the fraction of outcome variation explained by the model. It can be found that the precision loss is proportional to the fraction of outcome variation unexplained by the model. That is to say, the measures are in accordance with each other. Moreover, concordance is also a widely used precision measure. To describe it, we first introduce the conditional distributions of assigned risk among those who do and do not develop the outcome. The concordance is the probability that an assigned risk chosen from the distribution H1 exceeds that from H0. The table at the bottom shows all the precision measures of the previous example. It can be observed that with an additional covariate, the precision is improved. Both calibration and precision have their limitations. Calibration measures have limited utility for evaluating a personal healthcare decision risk model. The woman who needs to know her breast cancer risk requires a model that accurately assesses her own risk, rather than the mean risk in a subgroup of women with the same assigned risk as her. In the subgroup of same assigned risk, the true risk can be very different. For the precision measure, they are bounded by the unknown distribution of measured and unmeasured risk factors which the investigators cannot control. Finally, all summary performance measures are aggregates of obscure important information about subgroups of the population, which may limit their utility for some applications. Model comparison can be divided into two parts, comparing accuracy and comparing precision, and the comparison should be based on the evaluation of two risk models applied to the same population. The overall calibration of two models can be compared by evaluating the difference or ratio of their squared biases. Comparing the attribute diagram is also a good choice, and now I will introduce a new tool to evaluate two risk models, reclassification table. The table shows that some individuals aligned different risk by Model 1 can receive the same risk by Model 2. Thus, adding covariates to a model need not yield a more refined partition of the population. While expanding a model with additional covariates may actually decrease its accuracy. Generally, such expansion will increase precision. The issue is whether the gain is large enough to warrant the cost of the additional covariates. The precision gains are usually measured as difference or ratio of model-specific precision scores, and most of these measures are closely related. For example, the difference in precision loss for two models is just the difference between the models' variance, and both are proportional to the difference between the models' squared PO correlation coefficient. In particular, this quantity is called the Integrated Discrimination Improvement, IDI, which is also a famous precision measure. Another famous measure is Net Reclassification Index, NRI. It is a probability that Model 2 provides a correct reclassification of risks minus the probability of an incorrect reclassification. NRI can be positive or negative. Now, I will reproduce the process in the paper and illustrate my result. My method is first to simulate two risk-determining covariates for 10,000 women, and then use the formula given in the paper to get the assigned risk for Model 1 and Model 2. Here, we simulate two populations, A and B, for comparison. The picture shows the risk distribution for each model for each population. And then, we just do as the same process as the paper. Partition population B into several groups, and then assign each group the outcome prevalence observed in population A. We can see that in the diagram, there is nearly no point lie on the 45-degree line because A and B have different risk distributions. This also proves that we should evaluate two risk models applied to the same population. Now, let's see the precision measures. When expanding the model with an additional covariate, the model variance and PO correlation coefficient increases, precision loss decreases, which proves that an additional covariate will increase the precision. For the reclassification table, it also shows that some women assigned different risk by Model 1 can receive same risk by Model 2, and some women assigned the same risk by Model 1 can also receive different risks by Model 2. And for the first two groups, the NRI indexes are positive, and for the last three groups, the NRI index are negative, but the overall NRI is positive, which implies that the Model 2 improves the precision. More details of the simulation and calculation process can be found in the Excel file. Now, I will talk about the new types of application of the risk prediction model. Actually, other than breast cancer, the risk prediction model is widely used in medical field. Lung cancers, heart disease, and effect of some specific medicine are all used risk prediction model to do the study. Finally comes the conclusion of this video. As we use risk prediction models for different reasons, sometimes we want the model to have high positive power. Sometimes we need both high positive and negative power. We should balance the accuracy and precision to get the most powerful model we want. Besides, we should make use of different measures to get the result. Here is the end of this video. Thank you for watching.